and with a lot of hairs. You know, it's not me. This is the real one. And thank you very much for the organizers to ask me to speak about something that nobody takes care for many, many years, which is the brain. The brain in sepsis, who cares? You look at the blood pressure, the volume you give, the kidney, the urine, the yellow bag, all the things like this. The brain is silent, especially if you give some drugs to put the brain silent, which is called sedation. Then relax. You hope, you are sure, that what you do for the fluid, the lactate clearance, the pulse rate variations, the diuresis is good for the patient. But you have no clue, and I have no clue too, about the potential toxicity of the attitude we have for the global, the whole body resuscitation and the brain. But a couple of weeks after, you are so good. You saved a life. The guy is saved. It means no more assistance for all the other organs. He is totally crazy. He is going to another hospital to take care of him because he is losing a lot of cognitive functions. He's punching his wife, that I can understand sometimes, but he's punching everybody too, even good friends. He has an abnormal behavior. So we don't know, we speculate the potential role of some kind of brain ischemia or maybe some kind of brain edema plus ischemia following this to say, maybe we did something wrong during the resuscitation, but we have no clue. So finally, it's not easy to know what happens. Recently means recently, for the old guy like me, means less than 10 years. So recently, in 2010, this review was published. It was a very interesting review making the point on this perfusion of the brain, which has to be taken into account. And you see, they said that, sepsis-associated dysfunction, cognitive dysfunction, such as the delirium, is present almost for 70% of the patients. 70% of the patients is huge. And you can see that only when you stop the sedation and when the patient is starting to improve sufficiently to show the delirium. And the second point he made, which is a good point, is to say, is there any link between the cerebral perfusion and the brain dysfunction in sepsis? I'm asking to you, who is convinced that the perfusion is an issue for the cognitive dysfunction? Raise your hand. 2, 3, 4, 5, 6. The others are against. No opinion. Okay, it could be French. So the clinical and the experimental data on cerebral perfusion, even we don't know exactly what means cerebral perfusion, are essentially inconsistent because of the few papers, very small number of patients, very different conditions, different methods to assess the perfusion of the brain, and different definitions for the perfusion of the brain. So finally, it's not easy to get an overview and to give you a state of the art. I'm humble for that. I will show you some clinical data and you will make a decision at the end if it's important or not. So how the brain can be at least stressed by the circulation and the environment during sepsis. So we can have some hemodynamic stress conditions created by the sepsis and some metabolic modification which may in itself deteriorate the brain function, such as hypotension, hypoxemia, some kind of hyperglycemia or hypoglycemia, and we saw when we discussed around 2000 the tight control of glycemia. So we got a very clear response. So the risk of hypoglycemia was high and the mortality was increasing when you are doing the tight control of glycemia. But you have also at the same time in sepsis, in addition to the hemodynamic issues, you have the inflammation that we don't discuss too much usually when we speak about the brain in sepsis. But this is characterized, as you know, by a lot of mediators, release, and cells activity. And we don't know very well if the brain still has a good blood-brain barrier or not. And even it has a good BBB, this doesn't mean that nothing is crossing over, because we have some special areas, in the ventricle at least, where the blood is in contact with the brain. So finally, the brain is not totally isolated from the inflammatory processes, and you know the example for that with the cerebral malaria. The cerebral malaria is related to the malaria into the blood, the falciparum, but you die from the coma, and some important papers have been published along the last 50 years showing some kind of brain ischemia related to the inflammation and parasites, obstruction of the vessels in the brain, which was supposed to be responsible for the death of the kids. The second notion, which is important to remember, is that the brain is a controller, very strong controller for the peripheral immunity. In other words, if you do a stress somewhere, for example, cholecystectomy made with a general anesthesia, keep the communication between the brain and the wound or the needles of the surgery. If you do the local anesthesia, the epidural anesthesia, you stop, you block the information which is not transmitted to the brain, then it did not get any order because it did not receive the orders from the tissue. Then you change totally the inflammatory profile, and the complications have been clearly demonstrated to be reduced when you use local anesthesia. So finally, the sympathetic system and the parasympathetic system are key. Some important statement before. Just to remember, you are very good for the neurophysiology, but just to refresh. Sometimes we forget something, it's good to refresh. I put on the abscissa the cerebral perfusion pressure. Remember, the cerebral perfusion pressure is not the mean arterial pressure. It's the difference between mean arterial pressure minus intracranial pressure that you don't know, but you have the jugular vein pressure, or you get some venous pressure, which is not so bad surrogate of this. Based on that, when you change this cerebral perfusion pressure, you have several modifications which may occur. You know the cerebral blood flow autoregulation curve. You go within a large range of this perfusion pressure. The flow is stable if the oxygen consumption is fixed. But below or higher these limits, you have a linear relation between the pressure and the flow generated. At the same time, it's related to the vasomotion modification. Of course, when you are increasing the cerebral perfusion pressure, you constrict the vessels and the diameter goes down. But at the same time, you have the cerebral volume, which is varying according to the vessel size. If you constrict, you reduce the volume. If you dilate, you increase the cerebral blood volume. Then you can change the pressure inside the skull. And the oxygen extraction you see is almost stable until you reach the lower threshold for autoregulation. And finally, this is obtained at a constant CMAO2, but you have, as for the whole body, a level, a critical DO2, where the oxygen consumption of the brain is not covered by the supply. Based on that, you can say, is the brain circulation control maintained during the sepsis-induced or the septic-induced systemic inflammation? Nobody knows, and if not, how the brain circulation control is modified. So we don't care too much about it. Probably it's very important to consider. The second point is, what is the role of the resuscitation we do, particularly the fluid we use or the presses, and should we apply some simple tests to know how this circulation is behaving during the sepsis, such as autoregulation tests, CO2 reactivity, and this is an important issue linked with the lungs, so we can tolerate some kind of hypercapnia. Hypercapnia has a huge effect on the brain, huge effect on the splanchnic circulation, but usually when you say the permissive hypercapnia or tolerance for hypercapnia, who cares about the brain? This may change a lot of the situation. You see here, sorry it's a French name because when I did this was some years ago, and I was not speaking English, which is still true, as you can understand. But with these factors, you have huge factors which may modulate the activity of the brain vessels. And you see you have the neurogenic factors, the humoral factors, the physical-chemical factors, and hormonal factors, plus the modification related to the adherence of the white cells to the endothelial cells in the brain. The last point for this that you should remember is the control of this of the brain on the peripheral immunity, and this is done by the sympathetic chain sending the information. The information is modulated by the computer you have in the brainstem in this area, which is absolutely crucial, and then getting the information from the vagus nerve and then responding through the sympathetic pathway or the vagus nerve, sending orders which may modify largely the phenotype of the immune circulating cells. And this, in this way, the quality you put the brain may change totally the outcome of the patient. Just an example, the Crohn's disease, resistant to the anti-TNF monoclonal antibody, resistant to everything, treated with a vagus stimulation chronically with an implanted stimulator, is surviving without any more drugs. And that's an important demonstration that you can do by the brain stimulation, you can control the peripheral systemic inflammation. That's an important issue. So, acetylcholine is the mediator which is responsible for that. If you do the vagotomy, experimentally, you inject small amount of endotoxin, all the animals are dying. If you stimulate the vagus nerve before injecting a high dose of endotoxin, the animals are surviving. So in other words, the vagus stimulation is reducing the inflammation, protecting the death of the animals. I skipped this slide because, among the parameters, among the mediators, the IL-1 for the brain seems to be the most important one. So finally, in clinic, what do we have? How can we assess? I propose to use at least the transcranial Doppler. Nothing is perfect, but the transcranial Doppler is an adequate tool to have some indices of brain perfusion. You can do quite rapidly in your ICU the anterior and posterior perfusion with the middle cerebral arteries, the posterior vessels, and you have time to time the evolution of this. Velocity, blood vessel velocity is not flow because you don't have the diameter. For sometimes you get a good window, you see the diameter of the vessels, or at least the diameter of the flow, and then you can say something about the flow, but most of the time you are losing at the velocity. Velocity is not bad to assess the perfusion. Just an example, you have to remember what is a good flow. Good flow means some kind of good systole. You can see here, you are familiar with the Doppler, but the point in the brain is, because of the autoregulation, very low resistance. Passively, the blood flows through the brain, which means that you have a positive diastolic blood flow because the resistance are very small. And the resistance can change by several ways. You can have vasoconstriction, of course, but you can have also compression. If you get a higher intracranial pressure, you press the intracranial vessels and then you increase the resistance. It's not a constriction, it's a compression. But you can have also the obstruction, and we know the microclots during sepsis may play a role for this. Then you lose, when you have this elevated resistance in the brain, you lose the quality of the diastolic blood flow velocity. Then you see the best example is this one, is the brain death situation. You see here, systolic blood flow, velocity, and the diastole, you get back and forth wave, but at the end of diastole, you have zero or negative blood flow. This is a characteristic pattern for brain death, means elevated resistance and no perfusion pressure. This is the two ways you can get an abnormal Doppler. The SVGO2, which has been abandoned more or less by many people, like the SVO2 for the whole body resuscitation, I don't understand why, except that it needs to be put in or to be sampled from the jugular vein, but it works very well, and this SVGO2 has to be between 65 and 70. If it's below this, clearly the brain is not perfused enough. If it's higher than this, you don't have to increase the perfusion, but try to be sure that all the areas are perfused. Just an example to show that the SVGO2 and the transcranial Doppler can be do together. It's quite simple. You get here something which has been done for this patient, and you see the transcranial Doppler goes up, the flow to the brain goes up. At the same time, you see the SVGO2 goes up, so you perfuse better, and you did something positive for the brain. Some clinical data. So finally, I see here Jacques Creter and the group at this time, Jacques Beret. He is almost around 60 now, something, 60? 67, a young guy has plenty of time in front of him. And then he did this nice study, because there is not too many studies on that, showing the increase by dobutamine, the increase in the cerebral blood flow velocity, and then the jugular bulbar hemoglobin in septic patients. This is the first paper, and probably the unique one I found at this time, which was able to demonstrate that with the dobutamine, you increase the systemic blood flow, and this increase in systemic blood flow increases cerebral blood flow, and this increase in blood flow increases the oxygenation of the brain, as mentioned by the SVGO2. A couple of years ago, we have been to Cotonou. I'm sure you know the Benin. And if you have been to Africa, to make a measurement in Africa is a huge performance, I can tell you. I came with a colleague, Nathalie Clavier, and we spent 2 weeks in Cotonou to measure the cerebral malaria, because the idea was cerebral malaria is creating coma because of ischemia, cerebral ischemia. So we went there with all the material, 30 tons of material. Almost 50% of the material disappeared after the second day, so we lost a lot, but we can do some measurements in different patients having cerebral malaria compared to the severe anemia not related to cerebral malaria, and compared to the control. What we found, to make a long story short, is clearly the cerebral malaria is supposed to be ischemic. You see the systolic blood flow velocity, you see the diastolic blood flow velocity are huge. So it's difficult to have an ischemia for the brain with a huge blood flow velocity inside the brain. So finally, we found why the people were dying. They died because of hypoglycemia and not because of ischemia. Okay, so we moved to the last one we did a couple of months ago. We were testing if the fluid we give to the patient in septic shock were able to change the cerebral hemodynamic, and we compared this to the patients having control patients going to the anesthesia, and we compared this with the people having a brain injury with minimal systemic inflammation to see the impact of the systemic inflammation and the impact of the brain integrity. And we tested the role of the cardiac output increase, and we observed that only in the septic group, the mean arterial pressure increased with an increase in systolic velocity at the transcranial Doppler level, and the end diastolic velocity. The other two groups did not change at all the cerebral hemodynamic. And that's an important issue to conclude, to say that the fluid challenge, for example, in septic patients with a normal brain initially, increased the stroke volume, increased the mean cerebral artery velocity, both for systole and diastole, only in septic group. And then if you get a chance to remove some CSF to measure the inflammatory processes inside the CSF, it's increasing when you give fluid, because fluid may cross over the barrier and make some disorders in the brain. And this is mostly independent for the mean arterial pressure, because we observe even the same in patients who are not increasing the blood pressure. Thank you for your attention.